live streamed for the benefit of the general public who may wish to join us. We don't have any notification of anyone from the community that would like to speak today, but obviously if anything comes in during the course of the meeting, we will be able to manage that as we go through. So apologies for absence. We have apologies from Hassan Chan, our chair, which is why I'm here today to substitute for him and to take us through the agenda. And we also have apologies from Richard Watson. Is anyone else aware of anyone who wants to give their apologies to this meeting that hasn't already done so? So I think we're complete on that. Good. So we need to approve the minutes of the last meeting, which was held on the 5th of October. Can I ask colleagues if there's anything in those minutes that isn't accurate? Anything spotted? So I think we're content then. Frida's joining us now, we'll let her in. So I think we're content then that the minutes of the last meeting are an accurate representation of our discussion. There is only one item outstanding. Do we have Pam with us now? We do. Oh, do we? Let me just check. Yes, oh no, she was with us at our last meeting, but she hasn't yet joined us. So there's only one item outstanding, which is a question for our Chief Operating Officer, Pam Green. She agreed to provide information with regard to the expense occurred as part of any procurement exercise. I'm fairly confident that that will be done. But Emma, for the record, can you just get that confirmed by Pam when she joins the meeting or afterwards? Okay, so that takes us to item 6, and I'd like to welcome Ed, our Chief Executive, for his Chief Executive update. Over to you, Ed.
Thank you, Chair, and just wanted to start by thanking everyone in the local NHS and all partners about how incredibly hard people are working to keep people healthy and independent and to keep people protected during this time. So I just wanted to just express a debt of gratitude to everyone involved with the local health service at the moment. So there are probably 4 big blocks of work to talk about, but 2 of them will be definitely picked up in the agenda, so I won't go into depth on them. So firstly, vaccination is obviously gone right up to the top of the priorities given the new COVID variant that we now have circulating, and we saw a case at the weekend in Essex being reported. As a result of that, all systems are required to really accelerate their booster campaign, and I'm pleased to support we're in a very strong position in North East Essex to do so. We've already given 101,000 boosters in our locality, and we are accelerating week by week in terms of volumes. As an ICS as a whole, we're currently ranked 5th out of 42 systems for our progress with our boosters, and as a system we're currently delivering around 49,000 vaccines a week. With the eligibility criteria being widened in the last 24 hours or so, we're going to increase that delivery to around 60,000 vaccines a week over the next month or so. So a lot of work to do, but we've built a really strong momentum. I know we can do it, and there's huge commitment to do it from all partners and indeed volunteers. Urgent and emergency care and elective recovery, I think, are 2 enormous pieces of work which we'll pick up in the agenda, if that's okay, Chair. And then the 4th area I just want to talk around was transition to the new integrated care board and the new integrated care system. We have now appointed a chair and a chief executive. We go out to appoint non-executives to the integrated care board probably next week, and we're in the process to look at the recruitment of directors for the integrated care board too. So a lot of work underway Amanda's team have been doing the technical work around the close down of the CCG and setting up new constitution and looking at all of the contractual work. So a huge amount of work there, and that's currently green rated by NHS England. So I think we're one of the few systems that are making very, very strong progress on the transition. So thank you to Amanda and colleagues. So those would probably be the four main areas, Chair. I think, as I said, particularly urgent care and elective care will be picked up on the agenda. But if there are any questions on vaccination and transition, I'm very happy to answer them.
Thank you. And perhaps we can look forward to our future meetings when you'll update us on the results of those appointments.
Sure.
Any questions at all for Dr. Ed Garrett? I don't think so. I think we're content to move on. So thank you for your report. I'm a little bit concerned, Emma, that we don't appear to have Myrna with us, which is very unusual for her. Have I missed her on the attendance list?
No, I can't see Myrna.
That's very unusual for her not to give her apologies. So I'd be grateful if you could follow up to check that all is well with her. But thank you in her absence for submitting a brief report on the Health Forum Committee. We now have a much better mechanism for Myrna and her colleagues to alert us to any issues around coronavirus to clinical colleagues. So I don't think we need to worry too much about that. But for the purpose of the record, we thank her and acknowledge receipt of her report. So we'll move on to item 8, and that's you, Lisa, with the safeguarding annual report. Would you like to just take us through that? I think we're asked to note the contents. Is that right?
Yes, thank you. And I'll just pull out the some of the key issues. Thank you, Chair. So you'll note that there is an update on some of the initial health assessment performance, which, although improving, is really still a concern to us and still something that we would like to flag as a risk. We have seen some real improvement by ESNEFT around capacity to be able to perform the initial health assessments, but I think it doesn't feel like a sustainable and consistent process that we have in place at the moment, and we are exploring a digital process that tracks every component of the initial health assessment process that will be done and looked at with Essex County Council and our other Essex CCG colleagues. At the moment, it's a very manual process that our looked after children's nurse oversees through an actual Excel spreadsheet. So it would be good to have a better tracking system available, and I think that would help us to improve performance. One of the key areas that the safeguarding team just wanted me to flag to you is our, as a system, our ability to use unregulated placements for children in care. We're no longer legally allowed to accommodate children in care in unregulated placements, which I think we would see as a positive move. That obviously these aren't placements that have been regulated by Ofsted. That's not to say that unregulated placements are poor placements. It's just purely that we haven't got the assurance through Ofsted regulation. We do have 2 unregulated placements in North East Essex, which have been given permission to continue at the moment, but it's a real challenge for our county council as a number of placements break down following children and young people experiencing mental health issues, and is something that we need to resolve as a system. One of the other areas that actually Essex County Council alerted us to, they had an increase in requests for assessments, birth assessments, and alerted us to the fact that we seemed to have more teenage pregnancies. So we've done some work with our public health colleagues and Essex County Council, and actually we have had an increase of pregnancies by, I think it's 48% up to 20 years of age, and the greatest increase is in the 18 to 19-year-old range. That coincides with a decrease in contraceptive prescribing. So there is, and obviously, as I say, an increase in referrals into Essex County Council for pre-birth assessments from our midwifery teams. So we have a task and finish group that is working across our county council, our early years providers, our maternity support, to really understand that and look at how we can improve and ensure that those children remain safe. There has been some really strong safeguarding oversight of arrangements for refugees and asylum seekers, and some of the output and where they've been able to make some impact is detailed within the report. And also we continue to plan for the liberty protection safeguards. So still expecting the new legislation to come into force next year. We haven't as yet received the code of practice, so it's incredibly difficult to plan operationally what that will look like. But we are continuing to plan for the end of March, and we are doing that as a whole Essex approach rather than a SNE approach. We're working with our Essex CCG colleagues and Essex County Council on that. Thank you, Pam.
Thank you, Lisa. And unless there are any questions, which I don't see any hands up, I'll ask you, if I may, to move on to the patient and public involvement report. Again, asked us to note that report.
Sorry, couldn't find my mute button. So this is a paper of two parts. So it has the involvement strategy for commissioning activity as we transition into the ICB. We're required to have a strategy in place by March 2022. So Appendix One really details a 3-year plan, focusing very much in the first year on culture and actually putting in some of the blocks for making sure that we then in the second year can develop sustainable systems to move forward with patient and public involvement. We're really keen that within the new governance of the ICB, we want to make sure that the voices of our public and patients are at the centre of all our decision making, and that we really involve people in the cycle of quality particularly. So we know that we often have our public involved in procurement processes, in quality planning, where that can sometimes not then be consistent through the quality cycle, is that there's not that feedback loop and there's not that engagement post commissioning to understand whether the impact that procurement has made or quality improvement agenda. So we really want to improve that and make sure that we consistently, because we do have some examples of great engagement, but consistently across all our decisions involve people early on and make sure that we're feeding back to our public. We also really want to work very much at place space, understanding the community's needs and using the engagement to understand if change has been made. So the first part of the involvement strategy focuses on the 3-year plan. The third year is very much about taking stock and refreshing the plan. It's quite difficult as we kind of move into a new governance world, a new way of working, to really be able to anticipate what the third year needs to be. So we have left it a little flexible to allow us to be able to take stock and look at that. The second part of the paper just details our Q1 and Q2 activity, which shows you all the PPI activity and how the team have been supporting each alliance and the MDT programmes of work, so cancer, mental health, CYP, etc. And I think you'll recognise that for such a small team, actually they have done a huge amount of work. They are really beginning they're still quite a new team. We've asked them to deliver a lot of change. We've asked them to integrate significantly with providers and partners' involvement and experienced teams, and they are still on that journey, but certainly their work with our providers' involvement and experience teams, and working closer with communications and the wider engagement teams, is seeing some real benefit around bringing those agendas closer together and being able to deliver a lot more work. So that's great. And I'll leave it there. Thank you, Pam. Happy to take any questions.
Thank you, Lisa. Just a couple of points. I'd also like to thank the team for the support they give to the strategy group, which of course advises the board on a range of issues. I'm also really pleased to see in Appendix 2 the reference to the digital platform that you've procured. I think during the pandemic, citizens have become really many citizens have become quite comfortable with sharing ideas and input on a digital platform. Not everyone, but a significant number. So it's good to see that you're investing in this type of interactive approach. I'm going to take a question now from Pam, if I may. Pam.
Yeah, I'd also like to thank the team, Lisa. Sophie's done some incredible work with our neighbourhood teams and with the digital platform that Pam has mentioned. It's really helping us engage the community at a wider level, and being able to create themes and map those, the commentary around our community assets. I'd also like to say that there was great engagement with our health watchers over using that and developing that product. So I think they've really expanded their network in how they've and what they've looked at as good practice. So yeah, it's coming to life in the neighbourhood teams work.
Thank you, Pam. Thank you.
Thank you, Pam. And Mark?
Thank you. And this does look very good, this document. I'm pleased to see it. I just wondered how the sort of governance going forward, is it going to be everyone's responsibility on the new ICB board, or will there be someone who is there either as a non-exec member or an executive member who puts forward this voice and this good structure that you seem to be getting together, and all the different mechanisms and approaches to getting public patient involvement? But I just, with my current hat on, want to make sure that we are championing the cause of what a patient's perspective and view would be, because I do think this CCG has been fantastic in getting quality and care to people and improving that over the years. However, I still think we stumble sometimes with that patient involvement, and not having Myrna today, we can't ask her directly, but I like the new structures. I just wanted to ask about a bit of the governance going forward. Thank you.
Thank you, Mark. So if I can respond to that, so I will certainly be working, or the Director of Nursing for the ICB will be working closely with a non-executive director on quality, and public and patient experience will be part of that quality agenda. So the Director of Nursing and that NED I will see as being accountable for driving the quality strategy and the public and patient involvement strategy forward. With regards to the governance, there will need to be a forum that ensures and keeps that check and challenge on the strategy, I think. However, I do think, a bit like safeguarding, it is something that needs to wrap around all the committees certainly within the ICB. So we need to make sure that through all the committees, a bit like the equality impact assessments that need to be completed, there is a challenge to how are we involving the public and patients and making sure that the voice is there. And I think that will be something that kind of grows through this strategy. I think we're still a little way off that. I still think we haven't got aligned aligned agreement around and consensus around what does co-production mean and look like across the system. But I think that's what the 3 years is about, really driving that through everything. So a bit of both. I think we'll need within the quality board a patient involvement and experience arm to make sure that we are driving the strategy, but it needs to be picked up through everything.
Thank you, Lisa.
I think that's a good analogy, Lisa, with safeguarding, but as you say, some way to go. So I'm pleased to note that Myrna's with us. Thank you for joining us, Myrna. Could I bring you in now to comment on Lisa's report? And also, we've taken a look at the report that you provided for us earlier on in the agenda, the Health Forum Committee. Anything you'd like to add to that? Would you like to come in?
Thank you very much. No, I'm sorry about that. I've been trying for over half an hour to get on.
I'm sorry.
The link that I had just wouldn't work. I set it all up this morning like I normally do.
Yeah.
Came on, we couldn't get on.
I think we've all had those experiences, but thank you for joining us now. Over to you.
Yeah, I mean, I think it's been very difficult. We've had a very different sort of public engagement through the pandemic because we haven't had our public meetings, and I always found that the public meetings, we've got different people there that we normally hear from, and they were the ordinary everyday public, and often they did come with gripes, but it was very useful to hear what they had to say, and we could make sure that was put through. Not necessarily as a complaint, but something that I thought everybody should know about. And we haven't been able to do that because we haven't had public meetings. And a lot of people, even though they could have joined in our meetings online, haven't, because maybe they haven't got the equipment or the know-how how to do it. And so I think that's, to my point of view, we've not gone backwards, but we've had to try and do things differently, and I don't think we get the ordinary people when we try to do this, because it's so difficult, isn't it, to get them when we can't meet them and meet up with them. We get the complaints coming through to our admin. But we don't get a feeling for that, because we used to listen to people at meetings and be able to do that. And that's a shame. We've gone backwards, and I think now I was hoping that we were turning a corner and we would be able to do things slightly different again. But obviously, that's not going to happen. And it is difficult. I mean, I don't know how your people that deal with the public find it, but it is much harder. People aren't coming forward. I like to hear good things, and people used to come forward with good things as well as bad, and we don't get. They're not now. They're not engaging with us, and that's a shame.
Thank you, Myrna. I think you make a really
back to that.
Yeah, a really good point about listening. It's not as easy, is it, to listen in a digital environment as it is in a face-to-face environment. But I've no doubt, maybe Lisa wants to say more after Max has come in, but I've no doubt that this strategy, as she was referring to earlier, will start to reflect and align to the changing environment we're all in. I'm confident of that. So Max, would you like to comment, please, on this?
Yes, thank you, Chair. Just wondering about PPGs, and and there's quite a lot of reference to it in the report, and I do think they are kind of due for a bit of a revamp, and they are the bedrock really of the patient forum, and patient engagement, and I think actually also for general practice can be quite good for general practice in terms of being able to deal with some of the pressures that general practice are under, being supportive to the practice, having a good relationship with the practice actually can help, but be a bit of a buffer between the pressures that are coming from patients now very strongly, and we all know that the general practice is being put under massive pressure from patients, and and often subjected to quite a lot of abuse. So I just wonder whether we could really work on that. I know that a lot of that's in the report, but I think I would like to sort of emphasise how I think that's quite an important part of public participation.
Thank you, Max. I'm going to ask Myrna to come back in, and then Lisa might just want to wrap up. Myrna?
Yes, I just want to say that that's one of the reasons why we've set up this group that's been looking into PPGs, because they're all different. And when we have our PPG liaison meetings, which we have continued with online, we didn't in the beginning, but we started them up again. But not everybody has been joining us, So it's trying to get everybody to come online. They've all run so differently, and there's not really any rules, and if there are, nobody seems to know what they are, or that they just seem to do their own things. The most successful ones, I think, are where they have a really good, the people who volunteer have a really good relationship with the doctors and staff in their practices. And unfortunately, that doesn't. I know the practice that I belong to, and I'm not going to say which one it is, but as they're happy for us to be out there and having these PPG meetings and liaising, but they don't really get involved, and we take things back to them, and it's difficult to get some sort of answer from that, what they did, or if they did anything, and if they're trying to change. And I do think that seems to be the majority of the decision. I can understand it. They're so busy, GPs, and it's something else that they don't perhaps feel that they want to get involved in, and I can understand that when they're so busy. But I do actually believe in them, because when we had regular meetings and we had a lot of people come, it wasn't, people just didn't come with gripes. They came with good suggestions sometimes, and that could be fed back to any doctors that turned up. But less and less they just didn't turn up after a while.
Thank you, Myrna. I'll bring Pam in, and then we really must draw this item to a close. Pam?
So as far as I'm aware, PPGs and the structure around PPGs, whilst they need to revamp and a refresh, Lisa, we still see those as very important parts of our engagement strategy. They require they still are required in statutory engagement around changes to practices. So, Myrna, I think it's important that my team work with you and Lisa's team to get that right, because whether the GPs have got the capacity at the moment to do all the good things that they used to do around PPGs or not, actually there is very, very specific requirements. So if you're changing the practice boundary, if you're changing the accommodation, if you're changing the services, if you're changing the way people interact with the practice, actually that, good ideas, as you mentioned earlier, good ideas come from the PPG, but also it's a requirement we ask, and we will still be asking in the future, have you engaged with your PPG on that? So it's for us to role model that is required still as well, and keep asking for it, but also to support people and practices to engage with the PPGs. So I think if we can work with Lisa's fabulous team, I know the piece of work that we're doing in Colchester at the moment around the practices, that her team are really engaging with the PPG, and it's a critical part of that, and that's learning for the local authority in the way that they do planning applications, and it's helping everybody understand that. So I think hopefully we're coming out. I know we've got concerns around COVID again, but hopefully we're coming out of the the sort of restrictions on us doing the sort of wider pieces of work now.
Thank you, Pam. Lisa, can you conclude this item for us, please?
Yes, thank you. That was a really helpful discussion, and I absolutely concur. PPGs are critical to us. They are locally based knowledge around health, and they are really, really important to us to understand how not just primary care, but all our services are functioning. So will be critical part of the strategy going forward. But I think Myrna makes a good point about how do we continue to engage everybody, and I think in this new world, that is one of our challenges, making sure that we, as we transition into a more digital world, we keep looking over our shoulder and making sure that everybody is still there and with us. So that's what we want to do. Thank you.
Thank you, Lisa, for your report, and thanks for all those comments. So we'll move on then to item 10. Items for approval, and Jane and Paul, I believe, are going to take us through this item. Before I hand over to you, Jane, I just wanted to thank you and your team for this. It's an incredibly complicated piece of work. It took me a while to read it, I have to admit, and had to reread a little bit of it more than once, but really grateful to the finance team for the huge amount of effort that's gone into stabilising our budget in a very unstable environment. So over to you with thanks.
Thank you, Chair. So yes, as you say, Paul and I will do a bit of a double act, and so because it is a huge paper and it's the work of multiple teams across the CCGs. What I will do is just give a bit of introduction and talk about the narrative part. Paul will then come back and cover the activity and the winter plan, and I'll finally pop back in again at the end to talk about the budget. So, but just by way of introduction, I'm afraid it is a financial year of two halves. We unglamorously call it H1 and H2, and at an earlier meeting of the governing body, we brought the plans for the first half of the year, and what we're doing now is bringing back the second set for that period that started back in the beginning of October. So you'll see that the introductory paper sets out the various bits that we are bringing for approval today, which are the plan narrative, the activity plan, the budget, but we're also taking the opportunity to bring the winter plan because this is an incredibly important document, and we thought that it would be useful for the governing body to have sight of that and to provide any input and thoughts, just so you can see what's going on in those areas. But in terms of H2, the second half of the year, there are no huge surprises in terms of what the guidance set out for us. It really does build on the work that we've been doing all year and the plans that we put in place in the first half of the year. And just for information, the narrative plan for the first half of the year, which provides the context, is included as an addendum to the paper. So apologies, it does make the paper very long, but without that, some of the bits that we put in place for the second half of the year didn't really make sense. So as I say, thankfully, I'm hoping that not many people have actually killed off trees to have to print it out. But in terms of what we were required to do in the second half of the year, they're set out in the paper, the six main priority areas, building on what we were doing from the beginning of the year. It's around wellbeing of staff, it's around the vaccination programme, it's also around restoring services in elective care and cancer, work on primary care, transforming emergency care, and for all of those items, making sure that we work collaboratively across our systems and with our partners to deliver those priorities. So if Richard were here, he would take you into the first part of the approvals, which is the narrative section, which is included as the first appendix to the report. It follows a prescribed NHS England template, but it basically picks up on four of those particular priority areas as set out in the paper and talks about the specific plans that we've got in place on those. So hopefully, for people who've had a chance to read that provides kind of specific information on the actions that we're taking in those particular areas, and that sort of gives an overall context to what we're doing. That narrative has been submitted to NHS England, and we will get feedback on that in due course. Or Paul may know that we've already had feedback on it, because I'm going to hand over to him at this point now to talk about the activity and the winter plan, if that's okay, Chair.
Of course, thank you, Jane. Paul.
Yeah, thank you, Jane, Chair. So yeah, absolutely. I think essentially the activity figures flows from the narrative, if that makes sense. And just to echo some of Jane's words, that this plan and this narrative could not have been possible without the buy-in and the support from wider team members and partners throughout the ICS. And it's really a culmination of the various committees and groups, so cancer boards, elective recovery boards, people plan board, etc., which enabled us to really put quite a robust plan forward to NHS England. Having said that, we've had some really positive comments back on the plan in terms of what is expected to be seen in those plans. And as I said, the active figures flow from that in terms of the figures you would see in terms of expected attendances in A&E, right, so to the number of patients to be treated as cancer, and referrals, etc. So quite a lot of data and activity coming through some of our providers and checked with us at ICS level. I suppose the last point, which is a bit of a misdemeanor, when he talks about transforming community services and improved discharge, really talks about urgent care. And that's really quite a nice segue into the winter plan, which essentially has been put there for information. But I think it's important that we look at the winter plan through a number of lenses and absolutely understand the ask for the second half of the year. And I think we've got to acknowledge that COVID has not gone away. We have to acknowledge the effort around vaccination that we've already heard about in terms of cornerstone, what we do to protect our population. But we also got the uncertainty of flu. We've clearly got workforce implications. We've got a relatively tired workforce who's been going through, a couple of years of COVID waves, and at the time when we were asking them to start recovering services. We've got risks around rising activity, around emergency activity, and we've also got the issue of returning back to elective programme. And really the winter plan attempts to try and look at all those lenses and try and keep the business as usual going throughout the winter. So a multiple ask in the face of what is likely to be a very difficult winter for the reason I've just outlined. So essentially, there's been a number of approaches to the winter plan. There's certainly been an element of we need to improve our intelligence so we can understand where we can target our efforts. There's certainly been an attempt at coordinating our efforts, so hence why we have maintained sort of ICS tactical gold meetings and also place-based tactical to make sure we share all the relevant information and coordinate our response. Clearly a big focus on admission avoidance, trying to reduce the number of ambulances, trying to reduce the number of patients turning up at the front door of A&E. Clearly underpinning a lot of that is our demand capacity modelling, which is not part of the document, but essentially is an attempt to build on all the assumptions I've talked about, see whether we've got sufficient beds to meet the demand throughout the winter, and clearly a focus on increased resources, putting out community beds, and also additional beds within the acute sector, and also the challenges that are associated with our workforce. So the winter plan tries to put a coordinated approach to all of those things. And what you can't see within the document is actually sitting underneath each one of those is quite a detailed set of plans and conversations that have taken place to get us to this point. So again, a very big thank you to all partners with the system to enable us to be able to do that. The winter plan has been reviewed by NHSEI and actually has been positively received with a few minor suggestions in terms of projection, which we've been busy putting right. We've also had a meeting directly with Anne Ranmore as a system because of the concerns nationally and regionally around the activity and the difficult winter we're likely to have. And again, we had an extremely positive meeting in terms of our preparedness. And the last thing I would say is this winter plan is a winter plan at a moment in time. It will carry on evolving as the pressure mount or change as we move forward. Hence why we maintain our tactical readiness as part of the second half of the year. So I think I'm going to stop there and happy to try and answer any questions.
Thank you, Paul and Jane. Any questions for either Paul or Jane on the paper, which is it's a long read. It's a reassuring read in terms of the rigour of the process that underpins it. And I'm quite pleased to hear you make reference to the link into the tactical arrangements, particularly the tactical cell, which we've held this morning, which has allowed, I'll speak slightly off the agenda, which has allowed our community partners to respond very, very quickly to those pressures. So it's good to see there's a dynamic element to this. Thank you, Paul. Mark, would you like to come in?
Thank you. It may actually be something that you've just referred to. The tactical cell will deal with it as it goes on, but just in case Omicron variant continues to be of more concern and evades some of the vaccine cover that we do have, how will that impact this plan going forward and some of the catch-up work, etc., all of that? I'm sorry to suggest that is a possibility, but I just wanted to bring that out a bit further, Paul. Thank you.
Yeah, if I may just respond, Chair. So built within the plan is actually a certain level of variance in terms of COVID numbers of patients. So within the bed modelling is a proportion of bed that we are expecting. It's fair to say that we've got a number of COVID patients within our hospital, circa 25 to 30 on each of our sites at the moment, and that appears to be fairly stable. Built around that, and you may see as part of the winter plans, a number of trigger points. So actually it's something we are continually reviewing in terms of our bed flows. And there are a number of difficult decisions we may have to make as we move forward. It is possible that our elective active might be affected, but we have mechanisms in place to stop and restart our elective flow as quickly as we can. And we've already seen an example of that in Ipswich in the last few weeks, where there was a momentary difficulties around patient flow. We are constantly monitoring our hospital bed occupancy and actually our delays in discharges, and the focus that is really important. So essentially, we have a number of measures that we would adapt to as we move forward. So they are built within the plan. So it is something we are constantly monitoring. It is something we understand our tolerance zone around the bed availability, and we will have to make some difficult decisions based on productivity, shall I say, and the impact that might have should those predictions be exceeded.
Thank you, Paul. Thank you, Chair.
Comprehensive answer. Thank you, Paul. So are we happy to receive and approve the report? Jane, you need to come in to talk about the budget.
Budget. Is that okay?
Yeah.
Lovely. Shall I do that now, Chair? Is that okay? So, so just to finish off, I would say, last but definitely not least, the budget part of the paper, which the Finance and Performance Committee have kindly been through in a lot of detail and signed off before we in the required time for us to be able to submit it for region. But just to take you through what we've included in the appendix, it starts with the system position, because as CCGs we are coordinating the resources on behalf of the system, and then it moves specifically into the CCG. So just very quickly, it's on the background slide, which is page 130 for anyone who's following the packs. It really gives you the kind of highlights or features of the second half year funding, which are pretty much a kind of rollover of the first half of the year. They have been adjusted for the impact of the pay award and the backdating of the pay award. So the CCGs will pass the funding for both the CCG and our partners in terms of that pay award. There was a little bit of additional funding for urgent care capacity, which we've treated locally as winter funding. But there were some reductions in the overall funding on the COVID allocation that we were given and system efficiency. Martin, did you want to come in at this point, or?
Martin? You're on mute at the moment. Thanks, Martin.
Happy to come in now or after Jane's finished. So I was really just wanted to bring it back to our own financial position, which was that, we're still on target to break even. If anything, slight surplus, which will need to be managed well. But generally, from the point of view of the CCG as a statutory organisation, the finance, both Jane and Charlotte are doing it, and their teams are doing a cracking job.
Thank you, Martin. Jane.
Thank you, Martin. So, so carrying on in terms of the features of the second half of the year, we're pleased that the hospital discharge programme is continuing for the remainder of the year, but we've been given a very clear message that that will end on the 1st of April. So we are looking at ways that we can ensure that there isn't a cliff edge around that one. The Elective Recovery Fund, which was the fund put in the first half of the year to promote expansion and recovery around elective activity, continues in the second half of the year. However, the baselines have been made much tougher and the targets that we need to achieve. So we're not expecting there to be as much funding available to the system as part of that, but we have built lower levels into the plan and hopefully they will be achieved. So overall, the CCGs jointly received the funding for the system, which is round about, I just have to say this figure because it kind of shocks me every time, not shocks me, but kind of shakes me every time. We receive round about 1.8 billion on behalf of our population in Suffolk and North East Essex. So that money has been, we've worked through with providers, the elements that go straight through to providers, the elements that stay within the CCGs, and the elements that we distribute across the system. And I'm pleased to say that all partners, other than the hosted ambulance service, are in a position to have submitted second half year plans, which are in financial balance, making the full year be in financial balance. For people who want the detail, the next slide is the overall system allocation with all those ups and downs. If you take out the pay award, which wasn't in the first half of the year, and look at them on a like-for-like basis, because of the increased efficiency requirements and reductions in COVID funding, there's actually a 6.6 million less resource available for the second half of the year, but it is broadly online, and that's where you can see, if you add the two bits up, that overall 1.8 billion. I'm not going to take you through the next few slides, but they provide a lot of detail about all the various bits that flow into the CCGs and how they have been allocated, plus the overall assumptions around inflation and efficiency requirements are on the national assumptions page. So moving on into North East Essex specifically, the end of the presentation contains the details about the budget for the CCG, and as Martin's very kindly already updated the governing body, we are in the really positive position of being able to have put in a balanced financial plan for the whole year for North East Essex CCG, and we are working through at the moment to try and make sure that all of our resources are expended appropriately, because we do at the moment have some non-recurrent elements which are not yet committed. So we are working through plans to make sure that we get the best value from those overall resources for our population. So the presentation contains information on how the various elements of the budget have been put together, including non-recurrent investments already in train, cost pressures and efficiencies within the CCG. And we hope that this is pretty much there in terms of the budget for the remainder of the year. However, we are asking the governing body that if there are any final tweaks when we receive feedback from NHS England and Improvement, that we're able to deal with those through the Finance and Performance Committee. Thank you, Chair.
Thank you very much. That's really excellent. So I think we're now in a position to note and approve the report. That's item 10 on our agenda. Any concerns about that? Are we happy to give our approval? Yeah, I think we are. So thank you, Jane. Noted and approved. So as I said earlier, we haven't had any questions notified to us from members of the public, unless, Emma, some have come in during the course of the meeting. I suspect not, because you would have alerted me to that.
No questions have been received.
Okay, thank you. So we'll move on to our operational reports, all of which are for noting except item 12, where we'll come back to Paul and Jane. So let me go to Pam, item 11, the report of the Alliance Committee, please, Pam, which we're asked to note.
Yeah, thank you very much, Chair. So just as I always set in context when we refer to this committee, this is a delegated committee as a subcommittee of this board, and the decisions that we make cover the partnership decisions, and the full scope of the decisions the CCG makes over its funding, etc., are in the scope of the operational executive committee as well as the Alliance Committee. So the full broad range is covered in those two committees. So I think I'll take the paper as read, but the highlights that I'd like to give you is that obviously in order to support transition, we have been working with Tricordant and with a lot my mind's gone completely blank. Who are the other organisation that we're working with? Sorry, I will come back to me. Attain, sorry. Attain, that's it. Thank you, everyone. And we've used a number of our committee meetings since we last met to house that engagement around the future design of the Alliance committees working into the ICS and the ICB boards. So the business that we've done has been in slightly contracted form, but whilst we have had meetings, we have covered the work around the neighbourhood teams, and I'm delighted to say that the progress that we have monitored through the system executive group now means that the first teams should go live next Monday. That's the 6th of December, and they are fully engaging with each other around the development of the team, and starting to do test and learn approach to how an integrated team will work in a very broad range of partners. So that involves all health and social care partners, as well as the voluntary sector and our Colchester Borough Council colleagues, as well as the periphery. We will have organisations like Health Watch, as well as police, fire, those organisations supporting us in one system. So it's really exciting time for the Alliance, and the System Executive Group has kept a very close eye on that work, and thank you to my partners for ensuring the progress on that. We continue to receive significant updates around the Die Well domain, and that's one of the most developed domains within our Alliance, which is able to have a level of autonomy, which I think is because of the nature of the limited time frame, very sadly, that we work with people that enter the dying phase. It's a contained piece of work, plus we have very strong partners in our hospice driving that piece of work. So also we have really accelerated the work around the Clacton Place piece, which is significant because it chimes with the levelling up strategy of the government. So we've got support from Professor Marmot, who's one of the supporters of the North East Essex Alliance, as well as Dr. Bola Alawabi, who's NHS England, and she's their equality and diversity lead. So obviously something very significant around our equality and diversity within those deprived areas, and ensuring that everyone can fulfill their best life through the opportunities that we give them. So linking directly with our Health and Care Academy to ensure that people are work ready and able to support the vacancies that we have within our own anchor organisations. So very tightly linking that anchor piece of work to the levelling up work is the interesting piece that's happening at the moment. So I won't go into detail around the other areas. I will take questions on anything related to BCF and the slightly more administrative functions that we've overseen.
Thank you, Pam. Before we do that, can I bring in Councillor Mark Corey, who's chair of the Alliance Committee?
Thank you, Chair. I didn't want to add too much more, especially as Pam has just covered so much of the excellent work that's been going on. I've been privileged to chair the committee and to share that now as the Alliance Board has come together with the Alliance Committee, which makes absolute sense and has been making sense in how we've worked together so far. And I just wanted to praise as well the work of the transition workshops. I couldn't make the last one, but the ones before had been really open-minded, brought together staff from across the patch, primary care, communities, acute, and that has been really open and constructive, and I think that's the best way to go forward when looking at new structures and participation and engagement from all. So I thank those who have enabled that to happen in such an open way. Thank you.
Thank you, Mark. Ed, would you like to come in too?
Yeah, I think it's brilliant to hear all the progress and to be part of it. And my question was slightly different. So, Pam, if you were winding the clock backwards a year ago, 18 months ago, you look at where we are now, would you feel satisfied about where the Alliance has got to, or how would you feel?
So I am really grateful to this board for entrusting me and Mark to have the delegated authority that we've had. I feel that the governance and the structure that we've had around our alliance has enabled us to accelerate. And actually that on taking the benefits of the pandemic, if you can see it through that lens, that actually what we saw was a single aim of preserving life, and a unified approach to that across all of our partners actually galvanised us as an alliance. So I don't think I could have ever imagined we'd have got as far as we had got 18 months ago. The one area that I would like to see much significantly increased progress is around our programme management support and the traction around what we call the Change Management Office. I think that's the one thing that we haven't had as much infrastructure on. We're addressing that now, but it's the glue in the delivery of our huge projects and the huge amount of work that we're trying to deliver. So making all of these really good things sustainable is where I see our CMO really coming into fruition. I'd like to see some more progress on the contribution model. I still don't think we've got that well established between partners. It's still very reliant on what resources the CCG can free up, and for that end it means that they're inevitably non-recurrent resources, which gives us a level of instability. So getting everybody to get this as their kind of business as usual and reflecting that in their own governance, I think is where I'd like to get much further to, so that we can be a really streamlined system. But yeah, I'm very proud of where we've got to so far, and I really hope that as the future ICB develops, that actually the custodians of that will ensure that this progress is as fast as it has been over the last 18 months, and we don't have any retrograde steps around delegation. Is that a good enough answer, boss?
Thank you, Pam. And I would completely agree with you about the contributions model. It's going to be quite difficult to mature the alliance a little bit further than it needs to go without really bottoming that out. So I think it's also quite a responsibility on partners to step up, but I would say that, wouldn't I, as one of the partners that
yeah. And we're grateful to your support, Pam, and I think it goes wider than just officers. It's most definitely the enabling aspects, so estates, digital, you know, everything around engagement, communications, those things are all subject to the contribution model, because we've got a huge agenda to deliver. So leadership is one thing, but the broader infrastructure is absolutely key to the sustainability of the alliance.
I agree, and it's the next step in system-wide place-based leadership, isn't it? Good. Well, thank you for your report, which we've noted. There's no more questions, so we'll move on to item 12, which we do need to approve this report, and Paul is going to take us through it, and then Jane, I'm not going to forget to bring you in at the end to pick up on the finance report as well. So over to you, Paul.
Thank you, Chair. Clearly, this report has been through Finance and Performance Committee, so I am going to take this paper as read, but I'd like to pull out a bit of context, if I may. I think you need to look at this report through two different lenses and through two different contexts. One is the planning guidance that we've just been discussing in terms of performance, and to be clear, what we've been asked to deliver. We've been asked to decrease the number of 104-week wait patient and elective waiting lists. And SNF is doing very well on that, but I must point out this is a system problem, not just an SNF problem, and we got some inequity in waiting list distribution at West Suffolk. So again, a lot of mutual aid conversations are taking place, so it's not just about SNF's performance, but actually system performance. The second ask is around maintaining our urgent sort of priority elective surgery, what we call P1 and P2, i.e. the most urgent patients, maintaining our 52-week waits, and trying to contain our waiting list size, which is carry on growing for the time being. And finally, cancer recovery is an important part of what we've been asked to deliver in terms of performance moving forward. At the same time, on the flip side of the coin, we just had a conversation around winter planning. And again, just to stress the context of the performance, we are returning to pre-level of COVID activity, particularly around urgent care, which is causing some difficulties. We do have COVID patients in our hospitals. We do need to try and keep our elective recovery on track. and we also need to look after our workforce and ensure patient safety. So essentially, that is essentially the context of this performance report. Otherwise, you'd end up having a lengthy conversation about RTT, which is essentially not achievable at this moment in time, when actually it's a longer term planning in terms of moving forward. And of course, we are awaiting, the longer term planning guidance to come out as of mid to late December in terms of what the expectation might be for 22-23. So I think there's some key messages that come out of the discussions we've had around performance. And it's worth pointing out that SNE is the top 4 nationally in terms of activity. And again, not where we need to be. SNE achieved what it decided to achieve around the accident programme, which is 100% in terms of threshold. No other system achieved what they said they would deliver. So again, really quite positive. I do need to point out that our waiting list is carrying on growing, but it's slower than perhaps it would have been unless we'd made the efforts that we have. We are currently seeing a reduction in over 52 weeks, but I would predict that is likely to rise slightly before we get to the end of the year, given the winter pressures. We are clearly reviewing our cancer trajectories, and there's quite a lot of detail in the paper about the work that is ongoing, particularly around breast and other pathways. And it's also interesting to note that nationally, in England, SNF remained in the top 3 in terms of productivity for cancer. Part of the difficulty is around the level of activity that we are seeing come through in the hospital. So that sort of starts to give you a bit of reassurance in terms of the importance that the system is putting into cancer recovery. And diagnostics, you'll also see within the paper that productivity is carrying on increasing and improving, but the referrals are carrying on going up, hence why lots of conversation around community diagnosis hubs and other things moving forward is really quite important. If I was to pull out anything in terms of risk, and I'm sure Lisa may wish to come in on this point, you will see that as part of the report, it is pointed to lengthening ambulance delays and offloading, which is a particular risk, I think, for the system, not just for the system, but regionally as an issue. So I think I'll stop there, unless, Martin, you wish to add anything in terms of the conversation we had at Finance and Performance Committee.
Yeah, thank you. I'm just going to invite Martin in for his comments. So
yeah, I was going to say Paul has covered just about every base there, I think. I mean, we live in extraordinary times. One thing that I note from all of the stats that come across the committee is that we've got a workforce which is working at 120%, and quite rightly, that's not sustainable. I think it's very easy to look at a lot of the figures here and become a little bit despondent or perhaps downbeat. But I think what is very important, Paul has already alluded to it, is the fact that if you are a priority patient, if you've got something seriously wrong with you, you will be seen and prioritised. So we're really, the main challenge going forward is going to be recovering the elective situation. And whilst we have the current situation where we've got the workforce and so many resources under intense pressure, it's clear to me that it's going to take us a while to get on top of that. I mean, some of the stats are quite astounding. You know, although the 2-year waits are coming down, we still have over 1,500 people waiting over a year, 63,000 people on the waiting lists, and that's going up between 500 and 600 people a month. So obviously, whilst that is quite disheartening, I mean, I think I've no doubt in my own mind that, you know, as we do recover from COVID and going forward, as soon as the workforce start to recover a little, I'm sure that with Paul and the rest of the team's expertise, they'll gradually get on top of the situation. But certainly, you know, it's going to be interesting times ahead.
Thank you, Martin. So, Paul, do you want to come back before I bring Jane back into the conversation?
Yes, I just wanted to say, Chair, if I gave the impression of being overly positive, I am overly positive with the amount of work that's been done, but I cannot stress the amount of pressure the system is under at the moment. It is significant, and we shouldn't lose sight of that.
You're absolutely right. Good advice. Jane.
Thank you, Chair. I just wanted to take the opportunity on this paper to just report the financial position for the CCGs. It's included at the end of the Integrated Performance Report pack, and there's a note in there stating that there isn't a month 7 report, and that's because, as we talked about under the planning paper, we are in the middle of trying to get our plans approved for the second part of the year. So NHS England haven't actually got anything loaded up for month 7, but I thought it was necessary that the the board knew where we were at month 6, which is the latest finance report available. And as we've already discussed, just wanted to point out that the CCG is breaking even once we have reclaimed the necessary resources through the hospital discharge programme and elective recovery fund. Normal reporting should resume for month 8, and we'll be taking that back through the Finance and Performance Committee as normal. Thank you.
Thank you for reminding us of that. Okay, so no other questions. So we are happy to receive and approve the integrated performance report. Oh, I think I've missed Martin out.
Yeah.
Sorry, Martin.
At Finance and Performance, part of the performance aspect of the paper, we looked at polypharmacy, and I've taken an action to inform the board that there's been we talked about polypharmacy in the summer at some length, and OGE brought to the Finance and Performance Committee some details on a deep dive, in effect, what they're doing with polypharmacy at the moment. There's a whole national piece of work that's being done looking at this problem, and some of the stats that were given to us at and if we look at patients at 85 and 8 items or more of medicines, we're looking at 23% of the population are receiving 8 or more items, whereas the English average is only 5%. And that trend goes right the way through all age gaps. If we look at 55 to 64-year-olds, whilst we in North East Essex have 11.2% of people receiving 8 or more unique medications, the English average is only 3.6. So clearly, polypharmacy in our part of the world is not just representing a quality issue to our patients, but also we're probably spending tens of millions of pounds more on prescribing than we need to do, and that's something which the board needs to be aware of, because I think clearly we're spending far too much money on medication, and there's all the potential dangers to patients that go with that.
And as a member of that committee, I'm very aware of the support we get from OGE in relation to really trying to drive this problem down, and her description at the last meeting, last but one meeting of the polypharmacy progress was very encouraging. But these are sort of cultural issues, aren't they, that need to change, and that's going to take time, but we can rely on F&P to keep a very close eye on it. I know that, Martin.
Yeah, I think the main thing is the sheer magnitude of the difference.
Yes, I know.
Locally.
Yeah.
It's massive. And it's obviously clearly it needs to be addressed as a matter of emergency. And
it is being. Thank you.
Yeah.
Any other comments? In that case, we'll move on. Thank you both, Paul and Jane. So we'll turn to Lisa now for the Quality Committee. All of the reports in this section are for noting. Can you pick out the highlights just for us, because we've obviously had the chance to read the report, Lisa?
Sure, thank you. So we had a very packed Quality Committee in November. We had eight reports on various topics. And we also spent some significant time considering the quality performance of individual provider organisations. And I think one of the key areas and risks to quality that we discussed that I would just like to raise with this group is around the balance between our workforce and the demand in our providers. So across both our acute trusts, our ambulance service and our mental health trusts, we are seeing significant demand at a time when our workforce is tired and sickness has increased, and there is a bit of a cycle around people feeling that they're not meeting the needs of patients, and the impact of that emotional labour on our staff. So I think it is a really challenging time at the moment, and we are seeing significant issues coming through our serious incident reporting, particularly with the ambulance service, where we know that their ability to meet the acceptable time requirements to get to patients in different categories has been impacted on their workforce availability, and also some of the issues that they face at our acute providers. So we had lots of conversations about that, and also so the two biggest risks is around East and their ability to respond effectively to patients in the community, but also our CAMS inpatient areas and the general mental health and emotional well-being of our children in North East Essex. We have seen increased presentation, particularly last week, the week before, at Colchester Paediatric Unit, of young people with mental health issues. That meant that they couldn't remain at home and they were admitted to paediatric unit. We had 3 children at last week in our paediatric unit at Colchester General under a Section 2 or Section 3, the Mental Health Act, which is quite significant. And also, as I said earlier, around our placement breakdowns for children in care, which is often as a result of increased mental health issues. So I think that probably covers everything that we discussed at Quality Committee. Thank you, Pam.
Yes, you're absolutely right, Lisa. It was a packed discussion, a very productive discussion, and thank you for your report. Mark would like to come in there on this one.
Thank you, Pam, and thank you, Lisa. In terms of some of those discussions at the Quality Committee, but also in other places that we've had, I just wanted to follow up in terms of that report you've just given us and some of the points you've touched on, for example, with E-East, and for example, how you talk about staff suffering in a way because they feel they aren't able to give the care that they really are in the profession to do. And I absolutely empathise with that feeling and feel very sorry for them. We scrutinise on quality primarily for the patients, but we will not get quality if we have not got members of staff who are in the right frame of mind and are enabled to do their best work. So my point really is, thank you for your report. Thank you for pulling out that fact that staff are suffering as a result of not being able to fully deliver. And I don't think at all that is a fault of their own. And clearly it's the systems and the problems we have from hospital discharge onwards. So I want to ensure that we are supporting our staff because we have to absolutely have staff with as best mental health as possible during these tough times to deliver. So I hope that we're putting everything in place because we're all like-minded trying to give care to others, that we are caring for our own staff and making sure they look after themselves in order to react to the next challenges across winter and the sort of pinch points we have at the moment. So support everything you can do to support them in mental health and to function and to carry out their roles as best as possible. Thank you.
Thank you. And I can give you some reassurance, Mark, because we'll hear from Amanda later on with the health and wellbeing update. And the priority for health and wellbeing within the system has certainly been focused on in recent months. I'd be interested to hear Amanda's view on that later on in the agenda. So be assured on that front. OK, thank you for the report. Oh, I'm sorry, Frida, would you like to come in before we move on?
Just a very quick point I just thought of is that there is a stigma attached to seeking help amongst health professionals, and I think we have to recognise that. I mean, even after a number of years I've done, I still see resistance amongst my colleagues. Sometimes when I feel they should be seeking support, they don't want to because in case the regulatory authorities see put down on them or someone reports them. And I think this is a really real problem that continues in the NHS, that whilst we can treat people with mental health, we stigmatise it in ourselves as healthcare professionals. I just want to make that point on how difficult it is for people to come forward.
Yes, good point. So lots of work to be done, Frida, on that. Thank you. Martin, we're back with you now. REMCOM and HR committee report. We have it to note. Could you pick out any key issues?
No, I've got nothing to add here.
Nothing to add. Amanda, can I bring you in? Anything to add? The notice of the meeting is perfectly adequate.
Yeah, I think so. Thank you very much, Chair. So this is a typical agenda of the Remuneration Committee, and as you can see, the key items were on the workforce report, the health and wellbeing agenda, which I'll pick up later. So nothing out of the ordinary. Thank you, Chair.
Great, thank you. So Pam, we're back to you now with the procurement update, item 15. Again, anything to add or highlight from the report?
So no, this gives us the update from our procurement, current pipeline of procurement, but also the context by which we will be working. So I think it is very important to note that there were intimations around the white paper of change of procurement rules. The advice that we are getting is that until those procurement rules have been changed in law, actually we need to continue as we are. So we're expecting guidance on light touch procurement for health. But what we do know is that other organisations like social care won't have the same benefits of that at this stage. So our procurement strategy, and Paul is working on our procurement strategy as well, going into the ICB, needs to reflect current law. So that's contained within the document. And I also think that it's important to note that for Suffolk Fed, for our diabetes service, that's one of our most improved services since it's been under Suffolk Fed's leadership. We have managed to secure a solution with the Alliance under the banner of the NICS contract to ensure that our services to our diabetic population are secured and stable. So under the leadership of Suffolk Fed for the next 2 years, which is really positive news for people. So yeah, I'm happy to take any questions.
Thank you, Pam. Just make sure I haven't missed anyone. No, I think we're happy to accept and note your report, but we'll stick with you as we move on to primary care commissioning, the overview report, Pam.
Yeah, so I think it's very important to say thank you to our practices at the moment. There's been a lot of difficult media around primary care access, around the vaccination programme. They're under significant pressure, and also our thanks goes to Ed, who's written to our practices to say that he's expressed his full support to our workforce. I think from the comment that Frida's made, it's very important that we acknowledge the work that is happening in primary care and the increased demand that they're seeing well above 2019 levels. And we know some of the activity that's driving that. That's around people waiting longer on waiting lists, as well as chronic conditions not being as well managed due to COVID. So in the times that people were obviously shielding, etc. So we have received monies from government around access and winter initiatives, and the local medical council has been supporting us with that, medical committee, sorry, because there was some very strong advice from the BMA around engagement on those conversations. So we have established a number of schemes with that money to improve access, but we work with our practices in a non-punitive way to encourage them to improve access across the board, as opposed to the ask that was to look at the bottom 20 services across our patch. So it's really important that we keep morale up in primary care, and we work to ensure that long-term conditions and case management is the primacy for primary care, because that access and that care for the whole patient is managed in primary care. And they have the oversight of everything. So they are continuing to support us with the housebound vaccination programme. And again, we're very pleased that Suffolk Fed are working with our GP practices to ensure that those vulnerable patients that are housebound are getting their vaccination as quickly as possible. So there's a lot going on in primary care. I thought it was opportune to take that to this time to talk about those couple of things. And we continue to be very supportive of the vaccine programme within North East Essex, and are looking to do drive-through models as per the models that have been done in West Essex. And I can see Frida's hand's gone up. So she's either going to talk about access or the drive-through model, I'm quite sure.
Thank you. So would you like to come in? Actually, we had Myrna first, then Frida, and then Ed. Myrna.
Yes, I just wanted to make a point that what worries me is a lot of people aren't trying not to bother the doctors. And, you know, several people that I've spoken to really needed to see a doctor. And they were either too frightened to go because of the COVID and everything else, or they just realised how busy the doctors were. And I think most people are really concerned not to bother them if they can help it. And I think we could have a backlash from this, because we could suddenly find more people going into hospital because they haven't gone to see a doctor earlier, where it could have perhaps been something that could have been nipped in the bud. And, you know, or at least given them some help and support to get through the times now. And there's quite a lot of people out there that are actually doing this. There's not an answer to it, is there really? Because I've said to people, well, you know, you must go to the doctors. You know, they will see you. I've not had any problem, but they don't like to.
Myrna, it is such a valid point. So we find so frequently that those that need the most amount of support do not like to burden their GP, and in fact I've had a GP in my house today pleading with my father to please ring me, please come and see me, don't think you're a burden, because actually that case management and the long-term condition management is so vitally managed in primary care, and there is a reluctance in some parts to bother the GP, and I'd be really interested in working with you around the communications on that. But I also think that, and when we come back to our neighbourhood teams work, and when we're starting to connect our data up around who's using the services in our system and where could we have intervened early, actually we're going to find some of those cases, and we're going to find it in the data, and we will start to be able to make those contacts count much earlier. So it is a challenge, and it's, you know, it's the people we really need to get to, is those that probably don't want to bother the least, you know. So it's a conundrum for primary care, definitely.
Thank you, Pam. It was ever thus, wasn't it, in relation to the people that really need to go, putting themselves forward. So Frida, I'm sure you've got a view on this, which you shared with us earlier, and then Ed, and then Max.
Just very quickly, just a quick point about Suffolk Fed, actually. 3 PCNs have put themselves forward with Suffolk Fed to come and do their housebands, my PCN being one of them. It hasn't yet, I mean, in all fairness, it hasn't yet happened. So our housebands are still waiting for Suffolk Fed to liaise. It is happening, but it's not happening, and it won't probably hit the deadline by the 5th of December, which is a little bit of a concern. So I think we just need to be aware that the Fed is not quite working at pace as much as we would like with the housebound vaccinations. In terms of access, the problem is that we've got to look at innovative models in general practice. I think there's no doubt about that. You know, the old face-to-face manner, and all due respect, I think that is the perception of the public, and I don't blame them. Obviously, it's nice to go and see your GP. It's not always necessary, and we can do a lot of stuff in other ways: videos, photos, telephones, all kinds of innovative ways, although we get damned when we use too much innovation. We get put in the bottom 20% because we're using other methods. But having said that, you know, patients have to accept that it's not necessarily seeing the doctor that matters. It's about communicating with the doctor. I communicate with a lot of my patients via email. I say to them, write to me on email, and I'll write back to you. You know, these things can work if they're you know, in the right context. Obviously, there is a place for face-to-face, a large place for face-to-face, but I think the public has to start considering other models of general practice to allow for the increase in demand that is inevitable and is happening and will continue. So I think where we're failing is to accept one model.
I think your points are very well made, and they apply to the whole of the delivery of public services, in my view. So thank you for that contribution. Ed, and then Max.
Yeah, I was just going to build on Frida's point, because I think we just need to triangulate all of the data. So Frida's practice has the best patient satisfaction scores in Essex, some of the best in England. But as she says, they have very innovative ways of delivering, which don't necessarily, fit what the government might be looking for. So you've got to triangulate all of the data when you look at these issues. But if you look at North East Essex as a whole, on average, the practices are delivering 70% of their appointments face-to-face against an England average of 61%. So we do provide more face-to-face in North East Essex than on average across the country. And I think it's important that we put that point across.
Yes, so do I. Max.
Thank you, Chair. Just thinking a little bit laterally in terms of, I mean, there's been quite a lot of reference in these papers to population health management, and I'm just wondering if there are some solutions there in terms of taking some of the pressure off primary care. In terms of also reducing hospital admissions, taking some pressure off the system. We do know that there are groups of patients whose care isn't as well managed as it could be, and that is addressed. It has been in the past been tried to address by things like QOF, but if we actually took a focused look at populations of patients. I know other areas are doing that, and I can see that Ipswich and East Suffolk are doing that, and they've got Mark Shenton leading on it. But I'm not too sure. Maybe we should be accelerating that locally to try and get some better outcomes for patients and reduce pressure all around in the system.
Thank you, Max. And
would you like me to respond to that?
Well, I was going to say, I assume that you'll make the connection there with data, which you referred to earlier.
Yeah, so Max, there is a programme. All practices have signed up to the data capture with the PHM programme, not necessarily for all to do all the analysis, but certainly so that we can use all the data and that we can do that within our neighbourhood teams. So we're seeing some really positive work coming out of the PHM approach in Mid-Essex, and we're working with the PCNs and the leaders over there to see how they've managed to get as much traction, as well as obviously across the whole ICS footprint. It is absolutely the foundation of the neighbourhood teams. So the first task that the neighbourhood team will be doing as they form next week is evaluating their data and developing integrated strategies to deal with that population to support our practices, because there's a lot of medical things that come through GP practices, but there is also a lot of social issues, as you well know, Max, that come through the practice that we could have done and had an earlier intervention approach to. So we've got good buy-in for that, and we're also getting support from ECDAR, which is the Essex Centre of Data and Analytics, that are working with our BI team to get the PHM programme to do more than just health data sets, which we've always had access to. So it's a much broader scope. The broader the neighbourhood team goes, the broader the data sets have to be, the more work you have to put into data sharing agreements and IG toolkits, etc. But all that work is happening around the neighbourhood teams, and the practices and the PCNs will benefit from that.
I just wonder also whether there's a link with the NICs and how we actually progress NICs going forward.
So neighbourhoods is NICs. So yeah, the thing we shouldn't forget is that neighbourhoods is NICs. So the intelligence that will run through that contract is absolutely driven by the neighbourhood approach, and we're testing it in Central Colchester to start with, and then it will feed out to the wider contract. The teams will change the way they work. Teams will change the people that they get leadership from, all those sorts of things, depending on what the data tells us. We know we've got a higher prevalence of children's mental health issues in Central Colchester compared to what we've got in parts of Tendring, and we will make the teams up so that they are able to respond to that. And it will be data driven. It will absolutely be data driven.
And I suggest, Pam, that we take an opportunity probably in the spring to bring an update on that particular pilot and subsequent pilots that will go online after the launch on Monday.
Perhaps it's in the March.
Yeah.
If we do have a board in March, where however it falls, that we exit the current governance with that. So
agree.
Thank you.
Okay, let's move on then to Jane's report on COVID-19 resource allocation. Jane, anything to highlight?
No, thank you, Chair. So there's been one meeting of the committee since we brought the last report to the board. Nothing particular to highlight. We have looked at this at the Finance and Performance Committee, so happy to take any questions.
Thank you. No questions, so we're happy to note that report. Thank you, Jane. And back to you, Pam. Just had time to draw breath. The Area Prescribing Committee report. I think there's a minute of the meeting that you'd like us to note. I think maybe Pam's had to take a call, in which case can I ask the board if we're happy to note Pam's report? Just the minutes.
Can I ask something?
Of course.
Probably for Prashant. Oh, hello. Can you hear me?
Yeah.
Probably for Prashant if he's here.
I think he is.
Yeah.
Yeah, I am here, Max.
What was the
Can
thinking?
you hear me?
Can I ask, what was the thinking around DOACs and dementia?
Yeah, I think what happened in the discussion was we had come a full circle. I do not know whether you remember the discussions around the time when we were PCT and we were doing the same discussions for warfarin. Especially we're talking about high risk patients, all the people who need to be on warfarin, and the local prescribers, especially frontline and secondary care, being a bit risk averse. I think with the DOACs or NOACs, we've come a full circle again, because we've pushed through the agenda for having everybody anticoagulated, especially those who've got high risk, especially those with AF. Now people are, especially with the APC and especially with the EPUT team, the dementia arm of the EPUT team, now pushing forward with the agenda that we should now stop DOACs in these people because of risk of falls and harms and bleeds. So I think we've come a full circle with DOACs. We've got the advantage, and I think we're making the same discussions we were doing with warfarin about 10, 12 years ago.
Is there evidence to back that up, though, Prashant?
Pardon?
Is there evidence to back that up, Prashant? Because potentially we could be disadvantaging a group of patients, who could still benefit from DOACs, in terms of preventing strokes.
There is no evidence. I think it's all. The evidence for DOACs is still on the positive side, especially with preventing strokes. But if you're looking at our frailty indicators, our frailty scores, our polypharmacy, our people with in that age group who are in dementia with their CKD 3s and 4s, I think, and with the drive nationally to sort of not up titrate the doses or the medicines, but to down titrate and to try and stop a few, because these are the people who will then end up in the front door and be admitted for weeks rather than days.
Thank you, Prashant, for coming in to respond to Max's question, but Pam's back with us now. If you'd like to comment on the note of the meeting, Pam.
Sorry, apologies for that. I had to take a call. I have an unwell member of my family, so it's not for frivolous reasons. I think this demonstrates the point that I was going to make. So in the new governance, I think it's important that we find a route where these minutes and the items can be approved by a predominantly clinical committee. The governance is a little bit direct to the board on this. The APC covers the whole of the ICS, so it's very important that it has anchorage in the current CCG board structure. But I expect for the future that we will have this will sit alongside the remit of the medical director and the chief pharmacist that will be in the governance. So apologies that we're having such a detailed clinical conversation in this space. I think it's a reflection on the governance as opposed to a reflection on the content or the quality of the conversation happening at the committee itself. So Max, perhaps you'd like to work with us around the governance route on that.
Yeah, I was just wondering actually whether if like something like that had come through CRG, we would have had the opportunity to discuss it at CRG, and then you know, it's been approved at CRG as well. Yeah,
I'm happy to use.
That's the first time I've seen that. I was a little bit surprised just reading those minutes to see that. And that's the first. I don't think it's come to CRG, so I'm just a little bit surprised about that.
I'll work with Prashant for that to come to CRG ahead of board, so that we can have a summary statement ahead of on top of the minutes. Would that be good, Chair?
And obviously, there may be that's why I've asked about evidence, because they may be looking at evidence that I haven't seen. And I'll look it up myself. I'm interested now.
Yeah.
So Pam, I think your point's very well made. There is clearly a gap between the minutes being noted and then coming directly to the board. We do need that clinical intervention, because speaking for myself and no doubt some others are not particularly well equipped to be able to engage in that conversation. So thank you for that.
So we'll
leave that action with you.
We'll put that interim governance in with Max as the chair of the CRG, and Prashant is obviously present at that meeting alongside our other clinical leads. So
that sounds like a good short-term solution. So we'll move on to governance and corporate business, and we're back with you, Paul. Emergency preparedness. Again, we're asked to note the report. Anything to add?
Yeah, if I may, this is really a topic we don't often get a chance to discuss at board level, but nonetheless extremely important. So just to set a bit of context to this, we are all bound by the Emergency Preparedness Resilience Response Framework. And whilst there are no consequences in terms of performance, should we not meet the standard, we need to remember that it's bound through the Civil Contingency Act, and the NHS Act 2006 and the NHS Constitution. So in the event of something happening, if we were not ready to respond from an emergency point of view, then there'd probably be some questions to be asked. So really quite a vital piece of work undertaken by a relatively small team. So and the other sort of contextual point is we are a Category 2 responder, so we are duty bound to support NHSEI to essentially assess our level of preparedness across the system. So back in July, as the accountable emergency officer, I was written to by NHS to describe the process we needed to follow for this year, and it's fair to say it's a fairly light touch process. So it was essentially self-assessment, followed by tabletop review, then a review by NHS England. So you will see in Table 1 and Table 2 that it set out the threshold that needs to be met for fully compliant, substantially compliant, etc. And no short of 100% gives you full compliance. So that gives you an idea of the stringent nature of the scoring. The good news story is that essentially when you look at Table 2, we are substantially compliant across the vast majority and fully compliant for PPG. You'll note ESEC, which is not a knee service, essentially is not fully compliant. But again, I would just simply, because it's there, point out that there was something compliant fully 68%, and I think the rest were partially compliant. And the team are really confident they can bring that up very, very quickly with a conversation. So I think I'll leave it there. But essentially, a good news story is that given all the challenge we've had, that we've got a system that is substantially compliant against these measures.
Thank you. And I'd just like to add to that, if I may, Paul. So yes, a good news story, but my question would be, are we doing all we can to make sure that our plans are aligned across the system? So we all have different, all emergency resilience players have a number of criteria that they have to achieve in order to be rated as good. Is that connection there?
So,
level?
So if I can answer the question in two ways, the fact you got one paper got 3 CCGs demonstrate that 3 CCGs are aligned.
Yes.
Is the first point I would make. The second point, and whilst we've not included all of the appendix, we've included some of the appendix of all the if you want, the measures that are measured, so to speak, across the various providers. And we actively review every single one of those measures as part of the EPR network. So essentially, our team centrally review all of those and join up the dots between those. Essentially, why we then end up with one report that gives a system overview of our compliance. Does that answer the question?
Partly, but again, for a discussion outside the meeting, to what extent are we then engaged with not just providers, but wider system partners? I'm thinking about the role of the county council and also the borough and districts, where there's such an interdependence now of one system partner on another that it would be great to see this reflected in a place-based plan, emergency preparedness.
Yeah, but it's an interesting question. It's a question I've had over a different subject entirely, which I won't mention in detail right now, but you're absolutely right. I think this is purely NHS-focused organisation, which I think is your point. Apologies. I didn't quite understand your question. And you're absolutely right, at system level, we probably ought to do more work on that basis.
Yes. Well, let's have a conversation outside about that, and I can put you in touch with the right people, certainly in the local government sector.
I'll welcome that. Thank you.
Thank you, Paul. So over to you, Amanda. Health and safety. You've asked us to note this report. Do you want to raise any issues?
Indeed, thank you very much, Chair. So this is a typical report that comes twice a year to governing body. And as members will see, we last met at the end of October. And a lot of the discussion rightly focuses on ensuring that we have up-to-date risk assessments for each of the buildings that we occupy. We rigorously update, and we do publish to our workforce to keep them safe at the end of the day. We also discussed home working and what that might look like in terms of policy as we move into that direction of travel. And that's something that we are further embedding. So I'll leave it there, but very happy to take questions, Chair.
Yes, and I think there is a connection here, Amanda, between this item and item 23, because I know there are a number of concerns, aren't there, about general wellbeing for people either working alone or at home or both. So it'd be interesting to hear your update later on that. Any questions for Amanda? We stay with you now for the rest of the meeting. So we'll move on to item 21, the board assurance framework, please.
Brilliant. Thank you very much, Chair. So here we have our 10 risks, which is 10. All of the risks from last meeting have been duly updated by the risk owner. And before I invite director colleagues to comment on any of their particular risks, I just wanted to update on the first action or item, which was around primary care Clacton. And as you will see, we have £18 million worth of capital money that we were awarded a couple of years ago. And from a meeting earlier on that Jane and I attended, we are going to be updating the outline business case so that we focus on the relocation of one of our primary care practices, as well as updating more the narrative on the urgent treatment centre. So that piece of work is currently going to be preceded by NHS Property Services, and that report will then go through to the OP Executive Committee before coming to a future governing body. But I wanted to flag it today because it is a positive, and by doing that we then are doing everything we can within our gift to make sure that we don't lose that £18 million worth of funding, which we absolutely need to secure. And then in terms of the cyber risk, work continues with the IT team, and we continue to manage that as deemed necessary, and we provide regular updates to our audit committee on managing that going forward. I will invite other director colleagues to any update on any of their risks that haven't been covered elsewhere on the agenda. So Paul, or indeed Pam, do you need to add anything further?
Apologies, my Wi-Fi dropped out very suddenly. So no, I think, Amanda, from a risk point of view, looking at the risks that we've got in there, we've covered pretty much with the cancer, the elective recovery, the urgent care elements of within the earlier conversations, I think.
Thank you, Paul.
Pam? Anything to add?
No, I don't think there's any further update for me. It's covered within all the contents of the papers.
And then before I bring Frida in, Lisa?
No, nothing. Sorry, nothing to add, Pam.
Perfectly good reports. Are you content with that, Amanda? Can I bring Frida in?
Before we bring Frida in, can I just add one quick update, please, which will probably come back to a future governing body, but we have just been audited as part of our annual process, and we have been invited to proofread the latest report. And it was reasonably positive, actually, in terms of our approach to risk management. And they actually brought out a couple of areas of good practice, one being the regular risk forum that meets every month, where we actually do scrutinise each risk with the director risks in detail. And also they like the approach to our risk management framework. So the detailed report from the risk audit will be coming through to a future meeting, but I just wanted to share those key updates today to members. Thank you, Chair.
Thank you for doing that, Amanda. So we're very happy to note the contents of that report. Frida, would you like to come in before we move on?
Yeah, very quickly again, Amanda, thank you for that. And I'm really pleased with the positive about Clacton, actually, because obviously that's a real area of need. But as a tendering GP for 20 years and a PCN, the tendering PCNCD, I'd just like to point out that it's not just Clacton in tendering. There is a need of property services. There are so many, the level of standard of estate of primary care in tendering is utterly appalling. And whilst Clacton, and I absolutely get that is a need, but there are other areas within tendering that are in need of improvement, and yet we always get forgotten. I have gone through 3 expressions of interest, been rejected on 2 occasions, on our own premises, and we've had, and it just goes on, and there's other people as well, other GPs. And I think if you want to look at innovative working in a place like tendering, you've got to look at all our estates to be able to amalgamate and merge practices, particularly single-handed practices that are really struggling, put them into one site, let that be well run by the bigger practices. That's the way to get tendering in primary care forward, is to look at the estates. And nobody is listening to me. And I just want to take this opportunity, Amanda, to say that, because I just really believe that whilst Clacton is in need, there are other estates as well.
Thank you, Frida. Amanda? Oh, Pam.
Sorry, just coming off mute. Sorry, Pam, gone.
Okay.
So, Frida, we've had lots of conversations about this, as you well know. So we definitely sweat our assets in tendering. So if you look down a different lens, because we've got relatively small practices and increasing populations, we have the double jeopardy of being efficient in using the old dilapidated estate that we've got. However, we have had some benefits in, as you know, in Kennedy Way. We're looking at Clacton, and there to be bookable space there, not just for single practices, so that other practices can host their additional roles in other spaces as well. I think that is a major change that we need PCNs to be looking at. How do you work together to offer additional services, the additional services that government is looking at, so that we don't all try and recruit on those bases. So we share some resources and make an efficient model. We have tried in the past to get practices to move in together. It's not as easy as I thought it would be. There are a lot of driving factors around that, not to mention the public's access to the estate that they're familiar with using. But where we need to be looking is each PCN needs to have its own estate strategy. That will drive the investment. It will drive the mapping of the resources and the assets, and it will also enable other partners to start to think about their hub-based development of their estate that we can utilise for practice-based delivery. So I think there is innovation out there. I think it's got to be very, very different.
Can I just quickly come in just to say that we are tendering is a hugely rural area, and our practices are spread out within one PCN. So whilst we have an estates strategy, unfortunately we're not as lucky as in urban areas like Colchester, where they can actually bring their strategy to fruition. We have difficulty because we are spread over such a large. I mean, we spread from Clacton to Harwich, with Bentley in the middle, and our estates strategy has to look at developing our estates to accommodate that kind of rural area. And all I'm asking, I absolutely get Kennedy Way, and I really appreciate everything in terms of Clacton, because that was in need. But just don't forget the rest of tendering is what I'm saying. We are in need. And if we don't, we can't accommodate these additional people in any one of our 3 sites at all. And I think if you want good innovative practice like Prashant's practice, my practice, Harwich, which could be better as well, but still innovative, you need to help us with our estates. And I'm sure Prashant will agree with me.
I'll bring Prashant in now, but Amanda has committed to taking these helpful comments back to her estates team. Prashant.
Yeah, I would like to support Frida and echo her sentiments about the estates, because I think, yes, when the estates were sort of refurbished or made, there was mid-90s or late 90s. Unfortunately, the demand in primary care with regards to access and the variety of healthcare professionals working within our teams has increased so much. I think our estates or our demand has outstripped what we can provide within our existing estates. So I would support Frida on this point, please.
Thank you. We'll add your voice to the support to Frida's points that she's raised, which Amanda has agreed to take back to her estates team. So thank you for raising them both. So Amanda, the declaration of interest report appears to be more of an action for all of us to
Indeed,
check
it does.
that our interests are as up to date as they need to be. So that's an action for all of us to take forward.
Thank you very much.
And then we'll move on to our final item, which is the health and wellbeing update, which we referred to earlier. Amanda.
Brilliant. Thank you very much, Chair. So this is in keeping with previous reports that have been presented to our governing body on quite a lot of work actually that we're undertaking on all things health and wellbeing, particularly for our workforce. And as you can see in the report, we continue to do a lot of positive innovations that support our workforce whilst working in a combination of settings, whether it's actually at home or in the office, and we need to ensure that we provide all of that. And as you can see from the report, we have recently reignited our health and wellbeing group that is very much well attended by all directorates, and we recently asked them what areas of the focus should be going forward. And as we can see, mental health was clearly one action that we need to be addressing. And I think mental health, and given the conversations that we've had throughout this meeting, it's not wrong to seek help. And I think a lot of us think it's wrong that we actually put our hands up and seek the help of professional people. And I think as a good employer as we are, we need to be ensuring that we have got the necessary support and wraparound for the entire workforce. And keeping with that, as you will have noted from, I think it was last month's report, we recently again went out to do a risk assessment of our entire workforce, focusing on the health and wellbeing agenda. And it was really positive in something like 300 members of staff took time to go through their own individual assessment, have conversations with their current line manager, and together work through what additional support can we provide whilst we continue work in unprecedented times. In terms of mental health as well, we have a lot of active work across the entire system. We know that we have mental health hubs in each of our providers, which is available for all of our staff to access. And we also have a wider occupational health enhanced programme that we're working in partnership with Herts and West Essex. So a lot of that work continues. We also are meeting with our primary care wellbeing group next week. And this is a group that has been going and doing some great work for at least a year. And one of my senior HR managers, Sarah Isaacs, has been actively involved, and a lot of you around the room will be aware of that work. We have a next meeting, I believe it is actually next week, where we're focusing on the primary care wellbeing agenda. And what we're also wanting to be doing is actually looking through system workforce monies on what we can do to provide further support in terms of the primary care wellbeing agenda. So a lot of activity. We're not complacent. There is more that we can do, but I think it is fair to say that we are doing all we can locally through our CCGs to support our ongoing workforce, but actually we're joining up as a system partner to ensure that we've got the spread across the entire system, which includes health and voluntary and also local government. I'll leave it there, Chair, but very happy to take any questions.
Thank you, Amanda. I think your last point is a really important one. And also I'm assured in terms of the constant review that the strategy is subjected to. We've talked today, haven't we, about the rapid deterioration in some of our situations and the increasing pressure, and that's just going to grow and grow over the winter period. So I'm certainly assured that the support we give to our staff is under constant review, and that we're open to new ideas and ways of supporting people, going back to our previous discussion about health and safety at home, possibly for longer than we originally anticipated. Indeed. So any comments on that report from Amanda or questions? No, thank you very much, and we look forward to, Max is coming in just before I close the meeting.
I just want to say we just need to carry on the good work, to be honest.
Absolutely.
In North East Essex CCG, I think part of the setting up of the GP Wellbeing Group was because we recognised that actually there's a lot of good work that's gone on within the CCG with regards to the staff and the mental health champions and all that, and that wanted to reproduce that really in primary care as well and get that out into primary care. So yeah, just need to carry on that good work within the CCG.
I think we'd all agree with that one, Max. So thank you, Amanda. I haven't been notified of any AOB. Are there any items from colleagues? Doesn't look like it. So we've done incredibly well for time. I didn't feel our meeting was rushed. So thank you all very much. We'll be back together again on the 1st of February 2022. So until then, thank you very much, and bye-bye, everyone.
Thank you, Pam.
Thank you.
Thank you.